So welcome everyone to the second webinar of the Comprehensive Neuroanatomy Educational Program that organized by the many Neurosurgical Society in collaboration with the World Federation of Neurosurgery and Neurosurgery Forum and Neurosurgery Coach, along with the Pakistani Society of Neurosurgeons and Neurosurgical TV. Today will start our seventh session of the 13th of Module 2. And the moderator today will be Professor Khalid bin Madi, Professor of Neurosurgery at Hadramaut University, and one of the main figures in the Yemeni Neurosurgical Society. Professor Khalid, please, you can start. You can please unmute, Doctor. Professor Khalid, you are muted.
Okay,
Yes.
Dr. Ahmed.
Yes, now it's good.
Good evening for all. It is a pleasure to be here today with you, and I appreciate your time and presence here. Thanks for my colleague in Yemen Neurosurgical Society and Dr. Ahmed Al-Garadi, also with our speaker today, Dr. Sajjad and Dr. Shah. The topic of discussion today, I listen or I see that according to program, pituitary gland, anatomy of pituitary gland, and hippocampal formation. This is a good topic, and welcome for speaker today. Thanks for all member of Yemen Neurosurgical Society and my colleague in other countries.
Thank you, Professor. So now we can start with the Professor Dr. Sajjad Dawar, Assistant Professor of Neurosurgery at Khyber Teaching Hospital in Khyber Medical College, Peshawar. He will talk today about anatomy of the pituitary gland.
Thank you. Welcome, start.
Okay. Can you see the screen?
Yes, we can see it.
Okay. Thank you, Professor Khaled and Adul Aljad and the Yemen Society of Neurosurgeons for inviting me. It's a quite different thing when you teach the undergraduate because I'm also faculty for the Khyber Medical College, which is the most prestigious medical college in this part of the some 60-year-old medical college. So there is a lot of difference between teaching the postgrad and undergraduate. So the topic, I tried to make it as simple as possible and to avoid as many details as deemed not necessary for the undergraduate student. So starting from the scenario, a 45-year-old male present with 6-month history of progressive vision loss, particularly difficulty seeing objects on the sides, and frequent headaches localized behind the eyes. He also reports decreased libido and fatigue over the past year. On examination, there is a biotemporal hemianopsia is confirmed, but the rest of his neurological and endocrine exams are unremarkable. So with this scenario, when most of the patient neurosurgeons are sitting in the OPDs, outpatient department, we get this sort of patient, and the first thing that comes to our mind is that there is some problem with pituitary or cell area because the biotemporal hemianopsia is very specific for this sort of pathologies. So coming to the anatomy of the pituitary gland, this is me, and the learning objectives for the today is by the end of this lecture, the participant will be able to understand the embryology of pituitary gland, the anatomical location related structures, vasculature, hormones of the interior and posterior pituitary glands, clinical importance and pathology, some surgical approaches, a bit of, and some historical background of the pituitary surgery. So, pituitary gland is a small and oval-shaped gland that is attached to the undersurface of the brain by the infundibulum. The gland is sometimes called as the master gland, as it involved in many processes that is vital for life. So you don't go for the size, but for the importance, because without pituitary, life is unimaginable. I think the best part to learn anatomy is if you know the embryological origin and that how it originated, how it started making, then it become very easy to understand the function as well as the anatomy of the pituitary gland. So the embryological origin is that there is an oral ectoderm. If you can you see my pointer? You can see the mouse or not?
Yes, we can
Doctor?
see it, Professor.
Okay, okay. So if you just look at this ectoderm, this is oral ectoderm, which is going into the other ectoderm. That is the brain will develop from this ectoderm. So it goes inside it and pushes over here. So this the brain part of the ectoderm is moving downward, and the oral ectoderm going inside this brain room. So with this process, a pouch is made that is called Rutgers pouch. It start at 4 week of gestation, fourth week of gestation, and completed or 8 week, it become 6 to 8 week. It become discontinued, and just a remnant is there. Otherwise, you can see it become like this. Then it develops into the oral ectoderm and the other the brain ectoderm. They combine and make the pituitary gland, which is connected with the other part of the brain through the stalk. So this is the whole. If you can see that posterior wraps around the infundibulum stalk, and then there is a cleft, then which is a pars intermedius part, then pars nervosa, infundibular part, and a posterior. So these are the various part of the pituitary gland that will develop from the structures later on. Now, coming to the anatomical location and relations of the it has with a small depression in the sphenoid bone known as the sella turcica, which is basically it's called sella turcica because the Turkish saddle it is of this shape, and it resembles this Turkish saddle. That's why it's called sella turcica. Between the optic chiasm and memory body, memory is posteriorly and optic chiasm anteriorly. The superior surface of the gland is covered by reflection of the dura mater called the diaphragma sella. So this is the now we will discuss in detail all these relations, but just for sake of a quick view, the interior is optic chiasm, then the posteriorly is the intercavernous sinus, dorsum sella, basilar artery, and the pons. Superiorly is the diaphragma sella, as we have seen, and optic inferiorly is sphenoid sinus. You can see over here, and then left side is the cavernous sinus. This is the actual picture from this is the sphenoid sinus, this is the pituitary, this is the brainstem, this is medulla pons and midbrain, and these are the superior turbinate, middle brain, inferior turbinate, which is important in the surgical point of view when we do transphenoidal surgery. Now, if you look at the base of the skull, when the brain is removed, you will see that this is a lesser wing of sphenoid, and this is a greater wing of sphenoid bone, greater wing of sphenoid bone. Then there's the optic groove, and then there is a tuberculum sella. In between the tuberculum sella and posteriorly the dorsum sellae, this is the depression that is called sella turcica, where the pituitary gland is present, and this is the anterior glandal process, and just beside this, we have the most important structure of the arteries, and then the sinuses, cavernous sinus is there. So if you look into cadaver dissection, now this is sella, this is tuberculum sella, and this is the dorsum celli over here, and the pituitary is like over here. You will appreciate it over here. if you add structure into the picture, as so you can see that the pituitary gland is lying over here. This is the interior pituitary, and this is the dorsum sellae. The posterior part of the pituitary gland is hide behind these dorsum sellae, so it's not that visible. You have to you have to remove part of it, then it will become visible, and it is connected to the through the stalk with the hypothalamus. Over here, this is the internal carotid artery that it's all, and this is a paracellular area where we have just removed the sinus, cavernous sinus. If you add further, this is from the lateral side. This is the pituitary gland. We are seeing it from the lateral view, side view, and it's there in the sala turcica. Now, adding some further structures to the picture anatomically. If you look over here, this is the posterior lobe of the, and this is the anterior lobe, and this is connected to the third ventricle and hypothalamus to the pituitary stalk. This is the pituitary stalk, which is communicated with the third ventricle, because the hypothalamus makes the inferior floor and the lateral wall of the third ventricle. So it is connecting the with the hypothalamus. The stalk, pituitary stalk, is connected with the hypothalamus. So over here you can appreciate the chiasm, and that it is just above the pituitary gland, and that's why whenever there is there is a tumor of this region, you will see that it causes compression on the compression of the chiasm, and that's why the because in the chiasm the fibers cross, the crossing fibers of this optic nerve, they cross, and with at the cross where they cross in the chiasm, they are compressed, and that's why the biotemporal hemanopsia we get in the patient. So it compresses the chiasm over here, and that's why we see the patient the picture with the biotemporal hemanopsia. If we add some other structure, then you can see that this is the chiasm, and then we have added the hypothalamus. That is, this is the mammary body with that, and this is the pituitary stalk, and this is the pituitary gland, and the dorsum part of the. So it is connected with the hypothalamus, and then further with the mammary body, and with the other part of the brain through the pituitary stalk and the other structures. So it is very much connected with the hypothalamus. So that it's dependent on hypothalamus for various functions as well. This is another clear picture of hypothalamus, that we can see the pituitary and the hypothalamus structure, how it is interconnected, and how it is in coherence with the pituitary gland, because the hormones, some hormones are produced in the brain, and then it's just transported with the through the hypophyseal system that we'll later on read. It is bringing down to that level. This is a little bit of this, the interior hypothalamus and the posterior hypothalamus. The interior hypothalamus controls the posterior pituitary hormones. If you see that there are various nucleus in the interior hypothalamus, there's paraventricular nucleus that function is for the oxytocin release, and supraoptic various hormones. So basically the point to learn for the undergraduate is that the interior hypothalamus main function is to give hormones and control the posterior pituitary. So while the posterior hypothalamus is morely with other functions like satiety and even to control thirst and hunger and blood pressure, etc., etc. This is controlled by the different nuclei of the posterior hypothalamus. Now, this was a little bit of anatomic, the cadaveric, but just to revise that the pituitary gland is of two parts, that is the anterior and the posterior. The anterior called adenohypophysis. It is composed of glandular epithelium and the 60 number of hormones. It can be further divided. The interior pituitary can be further divided into pars anterior. This is the largest part, and responsible for hormone secretion, and pars intermedia, a thin epithelial layer that separates the pars anterior from the posterior lobe. You can see over here, and then pars tubularis, an upward extension of this pars tubularis of this that can just surround the anterolateral aspect of the infundibulum. This is infundibulum, and this is the pars tubularis. Now, the anterior pituitary gland is under control of the hypothalamus, so which communicates with the gland via neurotransmitters secreted into the hypophyseal portal vessels system. The vessel ensures that the hormones is concentrated and it's not diluted, and it's reached to the area where it should be and where it needed to be. While the posterior pituitary gland, the posterior lobe, that is also called as neurohypophysis, consists of the nerve tissue. That's why they say that the posterior pituitary is an extension of the brain. It's not the gland, but the hormones are made somewhere else, and it's just a storage and releasing point. It does not produce the hormone by itself. So it arises from the embryonic forebrain and is in essence extension into the hypothalamus. The posterior lobe secretes two hormones: the ADH, that is responsible for the control of blood osmolarity, antidiuretic hormone basically, and the oxytocin that is involved in pituition and milk secretion. Both of these are produced in supraoptic and paraventricular nuclei of the hypothalamus that we have seen, and then subsequently stored in the posterior pituitary, ready to release for the later use. Some of the vasculature, the anatomy of the blood supply and blood drainage. The vasculature of the pituitary gland is complex in a sense that it's not just the anterior and posterior hypophyseal arteries, but they have another sort of supply through the hypophyseal complex as well. So the arterial supply, that is a superior hypophyseal artery. Over here you can see this is the supply the ventral part of the hypothalamus, upper part of the infundibulum, and lower part of the infundibulum tubercle artery. While the inferior hypophyseal artery, the divides into medial and lateral branches, the two branches, and then the joint together to form an arterial ring that is around the posterior lobe of the posterior lobe of the pituitary. The branches of the arterial ring supplies to the posterior lobe as well as anastomose with the branches from the superior hypophyseal artery as well. Then the pars distalis, this is supplied exclusively by portal vessels. That portal vessels that we get from the upper part of the brain, arising from the capillary from the superior hypophyseal arteries. The long portal vessels drain the median aminus, drain to the median aminus and upper infundibular, while the short portal vessels drain into the lower infundibular. The portal vessel carries hormone releasing factor from hypothalamus to anterior lobe, where they controls the secretory cycle of different glandular cells. Then we come to the venous drainage. The pituitary venous gland drainage occurs through the anterior and posterior hypophyseal veins, which empty into the cavernous sinus. From the cavernous sinus, then the superior inferior petrosal sinus, and ultimately into the jugular vein. The hormones of the anterior pituitary are anterior corticotropic, anterior lobe is ACTH, the FSH, the follicle stimulating hormone, the growth hormone, luteinizing hormone, thyroid stimulating hormone, and protein, which in turn affect almost every part of the body. Oxytocin on the breast and uterus in females, and ADH on the kidneys. The growth hormones in the bone, muscles, and every part of the TSH is for thyroid gland, where thyroxine is regulated. The prolactin is also for the breast, and ACTH for the adrenal glands, FSH on the ovary, and LH from the testes. So these are the various functions that the pituitary gland runs from. The hormone of the pituitary we already described that it's ADH, antidiuretic hormone, also called as vasopressin hormone, and then we have the oxytocin hormone. Some clinical pathologies that we see, the most common is that of the pituitary adenoma. Then it can be divided in two parts, whether if they are non-functional or non-secreting tumors or hormone-secreting tumor. If it's non-secreting, then the pathology is the pathology it causes by virtue of its size and location. So it compresses upon the optic chiasm, and that's why because of the increasing size, the the surrounding dura is it's pushed and extended, and that's why they feel pain. There's a headaches, and with the compression of the optic chiasm, there is bitemporal hemanopsia. But and it's usually it is more in size. You can see macroadenomas more than 20, 30, or 40 centimeters. So this is because that it's because of the non-functional nature, it increases in size, and it is noted later on. But if it is hormone secreting tumors, then the hormone that it secretes, it will cause effect earlier, and that's why the most of the cases that we come to our clinics is the microadenoma cases, where they're diagnosed earlier because of their secreting hormones. If it's polyclonoma, the patient will come with the say milking from the breast from a non-lactating mothers, and even from males. If it's growth hormone, then you will face a prognatism, a huge increase in size of hands and feet, and so many other things. You can have also diabetes, early onset diabetes. If ACTH, then again they will have the Cushing syndrome. Then if TSH, these are rare, not that common. There's another tumor that is count from this as because of the origin is called the craniopharyngioma, that arises from the remnants of the earth case cleft, and it also compresses the pituitary gland, and most of the time it presents with the hyposecretion function, and because of the hyposecretion, then there will be an adult of 18 or 20-year-old which will look like a child because of the hormone suppressions, and it presents to us like this, along with headaches, vomiting, and pressure symptoms. Although it's not very much related with the anatomy, but as a neurosurgeon, we are more interested in the surgical approaches. So there is endoscopic skull base, open skull base, and both open craniotomy options are available. Depend upon the size, location, and types of tumor. If it's meningioma, then it's very difficult to do it endoscopically, and if it's adenoma, then it can be done endoscopically very easily. So depend upon the type, the lateral extensions, involvement of the structures, then we can do the surgical procedure, plan the surgical procedure. In transvaginal, we go through the nose to the sinus and then remove it, while in cranial approach, we do open craniotomies. This is a demonstration for an open case, and the previous one was for endoscopic case. Now, some historical background. Victor Horsley was the first person who attempted the surgical approach for pituitary gland. Who is the first surgeon who operated on pituitary, but unfortunately he was not successful back in 1889. Then the Harman Schlufer in 1907, he was the first successful surgeon that did surgery for the pituitary gland tumor using transvaginal approach. So performed the surgery through a lateral rhinotomy incision in the nose, not with the tonsil, but he just opened it with the nose, and he did that surgery. He resected the ethmoides, and sinuses altogether. Later on, in 1910, Oscar Harris developed the intranasal transeptal transvaginal operation. But the father of neurosurgery, Harvey Cushing, is considered to be that he really refined the transvaginal approach and operated on 231 pituitary tumors. In 1960, French surgeon Gerard Gouy used an endoscope in a transvaginal surgery. So this is because there was some time limitation, so that's why I tried to finish it before 9 the expected time. So if there is any question, I'm available.
Thank you very much, Professor. Dr. Khalid. You are muted, Doctor. Please unmute. Yes, Doctor.
Now, thank you. For doctor, sometimes in transcranial approach, complication may be done, likely diabetes insipidus and electrolyte disturbance due to retraction in infundibulum or pituitary stalk. some drugs used in this complication, like vasopressin and hydrocortisone. It is really rule for hydrocortisone in this complication. Some schools necessary to give hydrocortisone. And the other question about if pituitary apoplexy happen or done before surgery. It is emergency surgery. Really, some studies now, when there is pituitary tumor in patient and happen pituitary apoplexy, necessary as emergency surgical. This idea. Maybe clear this idea if you have any information about that to help us.
Thank you, sir. Sir, I will share our experience because we almost share the same sort of setups that we are. In the first question is about the use of the steroid and dexamethasone. So most of the time, then that we if the tumor is non-secretory, if it's adenoma, non-secretory adenoma, then I think there is no role, and we haven't used it any post-op steroid for this patient because adding steroid post-operatively increases the infection rate very much, and the healing process is very much hampered because the first 24 hours is important for the migration of the EGFR and all these things, the growth factor that are necessary for the healing problem. But if it is either other any hormone secreting tumor, then we mostly involve our endocrinology team, and they treat the patient as per the protocol of their blood samples, their various things, and they give the steroid post-operatively as well, because they said that if you just suddenly drops the level of these hormones, then it become sometimes it is an emergency situation where it can collapse anytime. So in secretory tumors we give, and in non-secretory tumor we do not. So coming to the second question, we haven't operated any single patient for apoplexy, and even 2 weeks back I operated on a patient who got the apoplexy that was almost that patient presented after 7 days, and he said that one day I just felt severe pain, and but then I tried some local GP and some medication, and there was no like what we have read in the book that it's the emergency situation, you have to operate in the midnight. No, sir, we haven't operated in the midnight, and at least in my practice, I have seen operated on 3 apoplectic cases that were presented late, and all of them were fine. I don't know if anyone died because of this, because we don't have so much data, but so far we haven't operated on any apoplexy patient.
Thank you, doctor. But apoplexy, I know that, but for medical or medical legal, some cases, one late not enter surgery, some people now it is emergency. Why don't enter case this for surgery? For medical legal, this is necessary to clarify for all neurosurgery. It is my opinion, not emergency. But
Sir, I agree.
hope to clarify this for all doctors.
Sure. I think the Neurosurgical Society should issue some sort of guidelines that it's not an emergency if it's not operated at midnight. So it will save many neurosurgeons from medical legal cases. I agree.
Thank you.
Thank you very much, Doctor.